In terms of genetic testing, this is important. In 2018, the recommendation came from our professional societies that all patients, regardless of their family history, should undergo genetic testing to see if they have a mutation in a gene that they inherited from their mother or their father that caused this. We find this in about 15% of patients, so it's not an insignificant number. And about half of those are in the BRCA1 and 2 genes that we typically link to ovarian and breast cancer, but also are associated with pancreas cancer and other cancers. And there certainly are implications for the patient in terms of their treatment potentially, as well as subsequent screening, and implications, of course, for family members. If they were to test positive, they could potentially enter into a pancreatic cancer screening program for early detection. So once we have this diagnosis, it's critically important to have a multidisciplinary review of the case. We do this at Yale in the context of a weekly tumor board, where we bring together all of the specialists who will be involved to review the imaging, the biopsy, to assess resectability, and to determine the initial treatment, particularly as it relates to chemotherapy. But multidisciplinary care doesn't end there. Throughout the care of patients as they go through this, there is multidisciplinary management at every stage. Often we will be using radiation, and we will hear more about that tonight from Dr. Du. We work very closely with our gastroenterology colleagues in terms of maintaining the bile duct stents, or in some cases duodenal stents, sometimes rebiopsying for clinical trials. And then we work very closely with our palliative care specialists to manage the array of symptoms that are associated with this disease. So I'm going to pivot now to treatment. And our treatment approach, as is true in all cancers, is based on the location and extent of the disease at diagnosis, or what we refer to as the stage. And as you can see here, we put really our patients into 3 groups at diagnosis. So on the right, or on the left rather, is the group that we deem resectable or operable. These are patients that have disease that's localized to the pancreas. We see no evidence of metastatic or distant spread on CT or CAT scan imaging. We see no significant involvement of blood vessels. These are patients that are potentially curable. But only 20 to 30% of patients do fit into this category. And the curative strategy for these patients requires 2 modalities. They're both extremely important. One, of course, is surgery, removing the tumor. And in addition to that, patients do need to receive chemotherapy for approximately 6 months. And the regimen that we now use, we'll talk about a little bit more, FOLFIRINOX. The reason we have to do chemotherapy is that 90% of patients at diagnosis, even if the disease appears localized, have microscopic or occult metastases. And surgery won't take care of the metastases. This is the role of chemotherapy to eradicate micrometastatic disease. At the other end of the spectrum are those patients, and it's about 40%, who present with obvious metastatic disease on their CAT scan imaging at diagnosis. And for these patients, we have effective treatments that significantly prolong life, but we still do not yet have a cure. And they generally are treated with chemotherapy. Only a small percentage of them will be eligible for targeted therapies or immunotherapies at this time. That hopefully will change in the very near future. And then this middle group, we refer to as borderline resectable or locally advanced non-metastatic. So these patients have no obvious metastatic disease, but their tumor has started to grow around blood vessels, making surgery more difficult. Some of these patients we deem borderline resectable. Others we feel are probably unlikely going to get to surgery. All of these patients will be treated with chemotherapy initially, and if the tumor reduces sufficiently in size, can go on to surgery. So most of the borderline patients will go on to surgery. This particular group, we've seen some very significant improvements in outcome with modern chemotherapy, FOLFIRINOX. The survival of patients with locally advanced disease really has doubled with the utilization of both chemotherapy, followed by radiation, and in some cases, going on to surgery. So chemotherapy is highlighted really for all stages of diseases, and it is the mainstay of treatment, from resectable to borderline resectable to locally advanced to metastatic. We have 2 chemotherapy regimens that we use. One is this FOLFIRINOX regimen, which emerged about 12 years ago for metastatic disease. and about 5 years ago for resectable disease. It's a complicated regimen with 3 chemo drugs and a vitamin, but it has really unprecedented benefit in all stages of diseases, and it is an essential component of the curative treatment. But the benefit of FOLFIRINOX, particularly in patients with metastatic disease, comes at the expense of quality of life. There is no question. It is associated with significant side effects, and it really can be a difficult regimen. The alternative is a 2-drug regimen, which is a little simpler and a little bit less difficult for patients, that has a key role in treating metastatic disease and an emerging role in treating the locally advanced unresectable patients. So I'm going to pivot now to resectable pancreas cancer. So these are the patients where we do have potential for cure. And about 5 years ago, there was really a giant leap forward in the cure rate of these patients with the release of data from our French and Canadian colleagues with the use of this chemotherapy regimen, FOLFIRINOX, which was compared to an older regimen, gemcitabine. And what they showed really was that at 5 years, about half of the patients were alive, and that compares to only about 20 to 25% of patients with older studies. However, there's a cautionary note here in that when we have had longer follow-up with this study, what we've seen that although half of the patients are alive at 5 years, and that is major progress, only about a quarter of patients are alive and cancer-free, which does suggest that we still are not curing about 75% of these patients. So there is clearly much work to be done. And we are looking for strategies to increase the cure rate. And there really are 3 things that are on the horizon. One is looking at giving all patients FOLFIRINOX before surgery and whether that increases the cure rate. The second strategy is to see if we can activate our immune system to eradicate microscopic metastatic disease. And then should we be using radiation either before or after surgery to prevent the cancer from recurring locally? I'm going to focus on the first 2. Sequencing of FOLFIRINOX. This is a really key issue for us right now. We do need to get the answer to this. There are some advantages, theoretical advantages, in that we will be addressing microscopic disease right out of the starting blocks, and that potentially could increase the overall cure rate. There are some disadvantages, which I think are relatively minor, but we really just need to learn whether this is going to move the dial. We've been very interested in this at Yale since we first learned about FOLFIRINOX over 10 years ago and began a Yale trial where we looked at giving FOLFIRINOX before surgery for 6 cycles of 3 months, surgery, and then more FOLFIRINOX for the additional 3 months after surgery. We built in a number of correlative biomarker studies to look at, and then we looked at our overall outcome. We've had long follow-up for this study and have looked at the efficacy, and it's very encouraging. The majority of patients are going on to surgery with a very high rate of successful surgery. And those that are able to complete the treatment, which was the majority, are doing well. We have not yet reached the median survival. So this is very encouraging. And then in addition, we conducted some correlative studies, including looking at the presence of the tumor DNA in the blood before, during, and after the completion of all therapy, and appreciated that we can detect it in the blood prior to treatment in most patients. And if the circulating tumor DNA disappears, patients are much more likely to be cured. We also looked at the patterns of DNA mutations and found patterns that may predict for a higher risk of recurrence. And we also looked at the presence of a protein in the tumor that appears to predict for a higher risk of recurrence. Now, this is important because we need to identify those patients who are not cured with our current treatment of FOLFIRINOX and surgery so that we can get those patients onto different therapies, better therapies, and discover more effective treatments. So this question hopefully will be answered in an ongoing national trial. We are participating in this study here. Dr. Kunstman, one of our surgeons, is the local investigator running this study. Patients will get 8 cycles of FOLFIRINOX surgery and then 4 more cycles, or will get surgery and the 12 cycles after surgery. It is a randomized trial, which means that patients will be assigned to their treatment and they do not get to choose, which is sometimes difficult for patients, but this is a key study. So shifting now to another strategy that is generating a lot of excitement, and that is, can we activate the immune system to eradicate microscopic cancer? Pancreas cancer is notoriously resistant to our current immunotherapies, but if we can combine immunotherapies with a pancreatic cancer vaccine, hopefully that will be more effective. And so this strategy has been tested, and it got a lot of publicity with an article in the New York Times earlier this year. And the schema of this particular study is shown here. And the idea is to generate a personalized pancreatic cancer vaccine for each patient. This was done by our Memorial Sloan Kettering colleagues. And what they did here was take patients who were going to surgery, tumor removed at the time of surgery, tissue rapidly processed and shipped off to Germany, where at BioNTech, which developed the COVID vaccine using the mRNA technology, analyzes the DNA, looks for mutated proteins that are potentially highly immunogenic, and then can make a vaccine with mRNA technology for those proteins. This vaccine then is shipped back to, here in this case, Memorial Sloan Kettering. After these patients have had their surgery, they will get a standard immunotherapy drug to boost the immune system, then weekly doses of the vaccine, and then they get their 6 months of FOLFIRINOX and then booster doses. And the preliminary study has been published. It was a small study, but extremely promising. The vaccine, called autogene cevumeran, is very well tolerated. It was able to induce pancreas cancer-specific immunity, and patients who had strong vaccine-induced immune responses experienced significantly fewer recurrences. So this is now being tested in a large study at multiple sites around the globe. We are going to be participating in this study, so we're very excited about this. It is, again, a randomized study to really answer the question as to whether this is a strategy that will increase cure rate. Half the patients will get chemotherapy, half the patients will get the chemotherapy and the vaccine and the immunotherapy. So I'm going to pivot now in the last few minutes to metastatic disease. We say this is treatable because treatment prolongs life, but it is not yet curable. The current standard of care is what we often refer to as endless chemotherapy. We typically don't like to stop for long periods because the disease can grow quickly. We don't have any easy pills to maintain remissions. The chemotherapy has significant side effects and impacts quality of life. In contrast to many other cancers, immunotherapy drugs, the ones that are available now, do not appear to work for the vast majority of patients, and targeted therapies are unavailable also for the vast majority of patients. So the promise of precision medicine with targeted therapies has been elusive in pancreatic cancer. But we are, I believe, are on the verge of moving the needle with precision medicine. So precision medicine, what is that? It means analyzing the DNA of the tumor, or what's called tumor profiling, and the proteins of the tumor to look for targets for which we have drugs, so druggable or actionable targets. Tumor profiling is a little bit different from the genetic testing that I alluded to earlier. That's testing the DNA of the blood or the saliva to see what mutations are present in the DNA that you're born with. This is testing the DNA of the tumor, where we will find mutations. But in pancreas cancer, we've had some challenges. One is it is actually hard to tumor profile pancreas cancer. We often do not have sufficient tumor DNA in our samples. We can do what's called liquid biopsies, but even that can be inadequate for the quantity of DNA. We have a real scarcity of therapies that are matched to the mutations that we see in pancreas cancer, and we still have insufficient knowledge on how to act on the genetic alterations that we do find. That said, since about 2017, precision medicine are moving into the arsenal of treatments that we have for pancreas cancer. They're shown here in red. I would say that only a small minority of patients are eligible to get these treatments, but this certainly is progress, and what we're working on is trying to expand the cohort of patients that are eligible for precision medicines. So the first sort of precision medicine or targeted therapy for pancreas cancer is a drug called olaparib. And this can be used in patients who carry the BRCA mutation, which is 5 to 7% of patients. And this has been shown to improve the duration of disease control in patients with advanced disease. And it's a simple pill that's taken twice daily. It's well tolerated and allows patients to get off of endless chemotherapy. So we have patients who have been on olaparib with BRCA mutated tumors for several years. Immunotherapy, such as drugs like pembrolizumab, do not work in the vast majority of patients, but about 1% of patients do carry a marker for sensitivity called mismatch repair deficiency, and those patients can get pembrolizumab. But for the vast majority of patients, we don't have precision medicines just yet, but we believe that is about to change. And that is coming from looking at targeting an oncogene or cancer-causing gene called KRAS. KRAS is present in many cancers as a mutated gene that causes the cancer, and it's present in over 90% as a mutated form in pancreas cancer. We have known about KRAS for 40 years, and we refer to it as the holy grail of cancer research because we have been trying to target KRAS for 40 years. It is a driver mutation. It causes the cancer. And only in the last few years have we been able to find drugs that inhibit KRAS and affect the course of the cancer. There are now 2 KRAS inhibitors that are FDA approved for a particular mutation called G12C, which affects about 1 to 2% of patients with pancreas cancer. But it establishes proof of concept that if you have a drug that targets KRAS, it can work in pancreas cancer. Now we have multiple other drugs targeting other KRAS mutations, in particular KRAS G12D, which affects about 35 to 40% of our patients, that look very promising in clinical trials. So now the promise of precision medicine, I think, is on the verge of being realized in this disease. And what we see in this pie chart here is that we have drugs in development in clinical trial that target the KRAS G12D mutation. We have other drugs that target all KRAS mutations. We also have a number of drugs that are already approved for other mutations that occur in our patients that do not have a KRAS mutation, which is only about 8%. But these are important because if we identify these mutations, we have drugs to treat patients. And then in addition, we are discovering other targetable, druggable targets, HER2 being one, where we have a number of drugs that target HER2 that we're bringing into the treatment of pancreas cancer from breast cancer and other diseases. We have olaparib, which we've talked about, which targets the BRCA mutation. We have drugs called ATR inhibitors that target other proteins that are involved in the damaged DNA in pancreas cancer. So I think it's a very exciting era, but particularly as it relates to targeting KRAS. And again, we have a number of trials at Yale focused on KRAS and other targets, and they're shown here in the red boxes, targeting KRAS G12C, targeting KRAS G12D, targeting ATR. And this is a very, very exciting era. So what about other drugs that are coming online that are exciting? So targeting KRAS does require that the KRAS mutation that you're targeting be present. But we have a number of studies that do not require a biomarker where all patients would be eligible, and I've just listed some of them here. All of them are combining new agents with chemotherapy. And so, for example, this particular study is with traditional chemotherapy and an agent that targets polyamines that looks very promising. We have 2 trials that combine chemotherapy with immunotherapy. We have a trial in patients with BRCA mutation that combines immunotherapy with olaparib. And then in patients who've had chemotherapy, we have another study with alternative chemotherapy and immunomodulatory drugs. So in addition to looking at KRAS and other targets, we're also very focused on bringing immunotherapy drugs online in pancreas cancer that do not necessarily require a target. So the pace of advances in pancreas cancer is accelerating. We really are entering a new era of drug discovery that's based on precision medicine, including targeting KRAS just in the last 5 to 6 years. And I think it's really a very exciting time, and I'm really hopeful for those of us that are involved in caring for patients with pancreas cancer. So just to finish up, why is pancreas cancer so challenging? There are a number of reasons. We don't have screening now for pancreas cancer. That's something hopefully that will change, and early detection and diagnosing patients at earlier stages, I think, should be an advance in the field. There are a lot of biological challenges to this disease, which has been why it's so tough, but we are learning more and more about the biology of pancreas cancer, and much of that science is going on here at Yale, and how we can overcome some of the biological challenges. And I think there's very little doubt that understanding the biology of this disease is going to lead to new treatments. So what is on the horizon? And I do think there is really much hope. After a number of decades of really not much progress. So we highlighted inhibitors of KRAS. This is incredibly exciting, and I think this story is going to evolve very rapidly. We talked a little bit about immunotherapies, and I think we are working very hard to render pancreas cancer visible to the immune system so that we can utilize immunotherapies. We're using drugs to disrupt the protective shield around pancreas cancer that sometimes doesn't allow our chemotherapy to get in. We're using drugs that can target the altered metabolism of pancreas cancer. We're using drugs that exploit the impaired repair of damaged DNA. These are all sort of science-driven, targeted approach to dealing with what has, to this point, been a challenging cancer, but I really feel we are at an inflection point with this disease and are going to see many new therapies coming forward, which will give us hope, much more hope for most of our patients. And so on that note, I will finish up.
Thanks, Dr. Lacy, for a wonderful talk. So we'll now move on to Dr. Harry Aslanian. Dr. Aslanian is a professor of medicine in the section of digestive diseases, director of endoscopic ultrasound, associate director of endoscopy, and director of the Yale Advanced Endoscopy Fellowship at Yale University. And he's going to be speaking to us about advanced endoscopic management techniques for pancreatic malignancy.
Oh, thank you so much. It's a great pleasure to be here, and so happy to be able to introduce the endoscopic management of pancreas cancer. This is a CAT scan of the abdomen. This is the pancreas here, and this is the duct of the pancreas, this little line here, and a tumor of the pancreas and the head of the pancreas. So we call this the tail, the middle is the body, and then the head has the potential to block the bile duct and the pancreas duct. So if we see a worrisome finding on a CAT scan or other imaging test, endoscopic ultrasound, or what we call EUS, is one of the first measures for further evaluation. And we can perform a biopsy with endoscopic ultrasound. We can evaluate a variety of cystic and solid lesions. We can manage the blockage of the bile duct, and we can manage intestinal obstruction. So I'll show you some pictures. The pancreas sits up against the small bowel below the stomach, and if it should block the flow of the food from draining from the stomach, we can improve that endoscopically. And we have some developing techniques to provide therapy for pain and sometimes even directly for the tumor. So endoscopic ultrasound, or EUS, is an endoscopic procedure that combines ultrasound at the tip of the scope with endoscopy. So the scope is passed through the mouth, just like a typical endoscope under anesthesia, and can very safely and comfortably be passed into the stomach. And we get very detailed views of the entire pancreas. So EUS is the most sensitive test for pancreas cancer that we currently have, and it can reliably identify very small lesions under 2 centimeters. We can see things even up down to a few millimeters in size. there's also a high negative predictive value for endoscopic ultrasound, and as we get very comprehensive views. Here's a little diagram showing that. This is the stomach, and at the bottom of the stomach, we can see the head of the pancreas. And by moving the scope in different areas from the stomach to the small bowel, we can see each area. So the pancreas, as you see here, sits in the middle of the abdomen, just behind the stomach. And here's a diagram showing the EUS scope with the pancreas sitting behind the stomach. So this is the pancreas tail, the body, and then the head portion. This is the stomach, and then this is the duodenum, the beginning of the small bowel. So you can see how the head of the pancreas sort of sits right against the sweep of the duodenum, and so it could potentially obstruct that. And then this is the gallbladder, the bile duct that drains liver from the bile from the liver, and it runs through the head of the pancreas. So a growth in this area could possibly block the bile duct or the intestine. So when we're performing EUS for pancreas cancer, what are the goals of that evaluation? We want to be able to obtain a tissue diagnosis. Under EUS, we can perform a real-time biopsy very accurately. And we also assess for signs of metastatic disease. We can look for lymph nodes around the pancreas. We can see most of the liver, and we determine the relationship of the tumor to the surrounding blood vessels. This is called local vascular staging, and this can influence the plan for therapy. So this is how a tumor looks on ultrasound, this kind of gray ball with it labeled T. Anything on ultrasound that's dark black is fluid filled. This is a blood vessel, so the mesenteric vessels live right next to the pancreas. And you can see how the tumor is sort of compressing and narrowing the blood vessel. So we want to see if the tumor is involving the vessels or separate from it. And then here's that kind of what we call hypoechoic or dark gray ball that we see on ultrasound. This is a mass in the pancreas. This is the ultrasound needle that we can very clearly see and move under live ultrasound viewing. And this is an example of the cells of adenocarcinoma, very large abnormal cells. And we can even look at the sample immediately as we're doing it, what we call on-site review, where we have expert cytologists look at the sample to make sure we're getting a definitive diagnosis. So why is it important to get a very accurate diagnosis? This is required for to initiate chemotherapy, and we typically like to have a diagnosis before consideration of surgery. So most pancreas cancers are adenocarcinoma, which is a tumor of the gland of the pancreas, about 90%. There are some less common tumors that might have a different therapy, such as lymphoma. Other cancers can rarely travel to the pancreas, such as renal cell carcinoma and melanoma. You heard about the neuroendocrine tumors, and there's other rare tumors and sometimes mimics of tumors that are actually inflammatory lesions. So EUS biopsy of the pancreas, what we call FNA, fine needle aspiration, or FNB for fine needle biopsy, is very accurate and safe. Accuracy is about 92%. Complication rates are less than 1 in 100. Rarely there'd be a risk of bleeding or irritating the pancreas. So this is the kind of scenario that we might be able to very carefully evaluate with endoscopic ultrasound. This is what a mass of the tail of the pancreas looks like. So this kind of extended dark area here. And then with the CAT scan, you can also look for metastatic disease. And these little round areas, what we call hypoechoic lesions in the liver, would be concerning for possible metastases to the liver. This is what it looks like under endoscopic ultrasound. This is the pancreas. This little dot is the pancreas duct, and that's normal. But you see how this very round, dark area is very different from the normal pancreas. So we can carefully image that. The scope is now in the stomach. We can look for the blood vessels, the Doppler flow, and this is the needle moving back and forth. So one of the nice things about this technology is that we're seeing these areas in real time. This is what we saw in the liver, this little dark area. It's only probably about 7 millimeters in size, and we can very precisely place a small needle safely into that area and obtain cells from both of these lesions. And in this case, this happened to be a neuroendocrine tumor. And then we analyzed the cells very carefully, and they can do special stains like fingerprint analysis to determine the features of the tumor. We also have a strong interest and frequently evaluate pancreas cysts. And these are very common findings. Up to 1/3 or even 40% of patients on high quality MRI scans of older age, over 70 years old, may have cysts detected in the pancreas. Fortunately, these are typically very low risk lesions. The risk of the most common type of cyst, what we call side branch IPMN or intraductal mucinous cyst, is thought to be about 5% over 10 years. And this is what it looks like on an MRI scan. This is the bile duct. This line is the pancreas duct. And these small circles are tiny little cysts of the side branches of the pancreas. So when we look at these, we look for high-risk features, which recent studies and guidelines, which myself and my colleagues have been able to participate in over the past 1 to 2 decades, have defined features of high-risk cysts and parameters for surveillance. For very high-risk cysts like this, those that have nodules that are large in size or thicken or rapidly grow over time, we can sample some of the fluid under endoscopic ultrasound, and we can analyze that fluid. For the most high-risk cysts that have features of early cancer or that were destined to become cancer, these can be removed with surgical resection. And we have a multidisciplinary team that looks at cysts in our pancreas cyst clinic. And my colleagues, James Farrell and Chavi Lohr, also run a pancreas cancer early detection clinic where the highest risk patients with genetic mutations or very strong family histories of multiple types of cancers or several first-degree relatives with 1 or more pancreas cancers may be candidates for pancreas screening. We typically do this with MRI and EUS currently, so imaging the pancreas typically roughly once a year to determine if there's abnormal growths developing in the pancreas. So let me show you one more example of the difference between a cyst and a solid area. So cysts are anechoic, so these dark black areas. This is the pancreas tissue here, and this is Doppler study. So this is a cyst that we're evaluating. The cyst happened to show up on CT scan, but this lesion here, and you can see the difference, how it's a much darker gray, kind of very solid looking area, happened to not be detected on a scan, and we were able to get a precise biopsy of that and determine that there was a cancer, solid cancer related to that cyst. And then we looked at how the pancreas sits next to the bottom of the stomach and the duodenal sweep, the first part of the small bowel, so it can block the bile duct. Here's a cancer of the head of the pancreas, and you can see how the bile duct here, the liver makes bile and it comes down in this direction and it can obstruct that. So we can use a different kind of scope called a duodenoscope and perform a test called ERCP, where we find the opening of the bile duct and we can pass a very flexible wire and a catheter and a flexible stent into the bile duct to allow the bile to flow and drain out of the liver. The signs of an obstruction bile duct would be jaundice or yellowness that also causes dark urine and lightening of the stool because it's the bile that causes the stool to be dark. There'd be elevated liver function tests. So those are blood tests that tell us that the liver is blocked and may be associated with pain and fever. Here's an example. This is the scope on X-ray. This is a dilated bile duct. So the bile duct is trying to come down this way. There's narrowing as it tries to get through the head of the pancreas. This is what the stent looks like on X-ray. So it's a soft mesh tube. You can see this narrowing where it's pushing open the bile duct as it's compressed by the tumor. Duodenal obstruction, so that's the small bowel below the stomach, occurs in about 1/5 of patients with pancreas head masses. we can place a stent similar to that into the small bowel to keep that open as well. This is what the stent looks like. It's a soft woven mesh. And here it is, a diagram showing it in place. So it has a radial force, so it keeps the intestine open. This is what it looks like on endoscopy. We see the narrowed lumen and then the stent placed endoscopically. And the symptoms of duodenal and gastric obstruction would typically be nausea, vomiting, because the contents can't get out of the stomach, bloating, but due to that fullness of the stomach, and loss of appetite. We have a new stent that has been a great advance for us in the past 10 years or so. We call it a lumen opposing stent. It's sort of dumbbell shaped like this. It has two sort of dumbbell-like structures and then a coating over that mesh. And this allows us to treat areas that weren't previously accessible, because we can oppose and bring two structures together and bring them up against the intestine to provide useful drainage. And this is a diagram. Sometimes instead of going directly into the wall of the small bowel, we can make a bypass, such as what a surgeon would do to connect the stomach to the small bowel further down that's not obstructed. This same type of stent you can see here can be passed safely through the stomach or small bowel into the gallbladder or the bile duct. So this gives us another route of drainage if necessary, if the scope cannot reach its usual target. And we also, of course, have very excellent interventional radiologists. And so we're able to do some of the things that our interventional radiologists can do through the scope currently with this device. I'll briefly show you another example of this. This is a dilated bile duct. So this structure is filled with bile. This is that catheter that carries the stent on it that enters into the bile duct that was passed through the duodenal wall. And then we also use X-ray to get additional information. This is the scope. This is the spine. This is the contrast in the dilated bile duct. And it wants to be draining down this way, but the tumor is blocking it here. So then this is the stent being opened into the bile duct. We open one side inside the bile duct and then the other side inside the intestine. And this is what it looks like from the endoscopic view. So this kind of provided a side drainage route, and you can see the dark bile now being able to drain out through this stent through the duodenum. So this is a very useful alternative. This is a diagram of how we can use this device to drain the gallbladder as well. Over the past decade or so, there's been a continued strong interest in using these same imaging techniques and very accurate access to the pancreas to provide therapy for pancreas cancer. One of the most established therapies is using EUS to bathe the nerves around the top of the stomach. There's the celiac plexus, which we can identify that those structures around the blood vessels near the top of the stomach. And then we can carefully place a needle next to those structures and bathe them in a solution of alcohol and numbing medicine. And that reduces the pain signal from those areas and has been shown to decrease pancreas cancer significantly in about 3/4 of patients. And then lastly, there's a sort of growing field of using, instead of just a diagnostic needle, a device that can ablate tumors with radiofrequency ablation. So that provides a very calibrated heat energy to coagulate the tumors. And this is an example, again, of the scope inside the stomach and the small bowel, the pancreas with the lesions nearby. And in particular for some symptomatic small neuroendocrine tumors in patients that may not be able to undergo surgery, we can ablate these lesions and improve the symptoms of these hormonal tumors that secrete excess hormones. Well, thanks so much. It's been a pleasure to be able to introduce you to the world of endoscopy. And these are my colleagues, in addition to the multidisciplinary specialty team. We're fortunate to have a large group of advanced endoscopists. And thanks so much.
Great. Thank you so much, Dr. Aslanian. Just a reminder, if you have a question, please drop them into the Q&A. We'll try and answer some at the end live, and we'll also answer some by typing in answers. So next up is Dr. Sajid Khan. He's Associate Professor of Surgery, Section Chief of the Hepatopancreatobiliary and Mixed Tumors Program at Yale Cancer Center, and Co-Director of Team Science for the Yale Center for Clinical Investigation. It's all you.
Okay. Okay, thanks, Mandar, and thanks for coordinating and moderating this session, and what wonderful talks from Dr. Lacy and Dr. Aslanian. So over the next 15 to 20 minutes, I'm going to talk a little bit more about some of the advances in the treatment for pancreatic cancer from a surgical perspective. So this is a slide that's commonly used in many of our medical meetings, and it's from the American Cancer Society, and it shows the top 10 newly diagnosed cancers in the United States in males and females. And when one takes a look, pancreatic cancer makes the top 10 list in both males and females, accounting for 3% of newly diagnosed cancers in males and 3% in females as well. However, when we look at the top 10 causes of death related to cancer, pancreas cancer rises up to a higher point on that list, and this is based on data from last year. And right now, it is the number 3 cause of death related to cancer in men and women. And by 2030, as you've heard from our prior speakers, it's predicted to be the number 2 cause of death in cancer related in the United States, which is pretty striking. Pancreas cancer is not just a problem in the United States. 64,000 people are estimated to be diagnosed with pancreas cancer this year, but today is World Pancreatic Cancer Day, and it's a worldwide problem, and nearly 500,000 people are diagnosed with pancreas cancer each year. And unfortunately, not just are patients diagnosed with pancreatic cancer, unfortunately, many patients that are diagnosed die due to pancreas cancer. And some of the great talks that you heard from Dr. Lacy and Dr. Aslanian, there's a lot of work that's being done and a lot of positive momentum that's being done to try to get these numbers down. And the last 5 years, I think a lot of us in the field are very excited about some of the work that's being done, such as Dr. Muzumdar in his lab as well, too. The 5-year overall survival for pancreas cancer in 1977 was just 2%. In 2023, it's improved, but it's still only 12%, which means that we have a lot more work to do in our combat against pancreas cancer. So some historical perspective about surgery for pancreas cancer, because when one thinks of surgery for pancreas cancer or pancreas surgery in general, it's thought of as a very morbid, high-risk operation. So, you know, the first larger description of pancreas cancer was in 1935 by Dr. Alan Whipple, who published his experiences of 3 pancreatic duodenectomies. And because of that first experience and his popularization of this approach, this operation has now come to be called the Whipple procedure. And in 1970, the mortality or the death after a Whipple procedure was 30%, which was obviously extremely high and too high, and had fallen out of favor in the earlier parts of the 1900s. However, there was a lot of work that was done in the 80s and 90s, starting with Johns Hopkins and many other centers throughout the United States. And that number for death related to the Whipple procedure has decreased to 2 to 5% nationally, and in centers such as Yale, that number is on the lower end of that spectrum, such as 1 to 2%. So a lot of advances have been made to allow for that. The perioperative morbidity, which are complications, is 40 to 60%, but even though that number might seem high, there's been a lot of advances that have been formed in that perspective as well, too, because many of these complications are managed very nicely by people such as Dr. Aslanian and our interventional radiology colleagues who can salvage patients without a reoperation. patients that do get to surgery with the curative intent, so Dr. Lacy talked nicely about resectable, borderline resectable and locally advanced pancreas cancer, but patients that we get to a curative intent pancreatectomy can have 5-year survivals of 20 to 25%. The goals of when a surgical oncologist, when we see patients with pancreas cancer, our goals are to potentially cure patients, to prolong one's life, and to maintain or sometimes even improve their quality of life. So those are the 3 things that go through our minds at Yale Surgical Oncology when you see us, and others in the country as well. And so as far as some of the advances that have enabled for better outcomes related to survival, not just from a perioperative standpoint, but also in relationship to the cancer, we've had a better understanding of the tumor biology in recent years. And there are these types of lesions that are precancerous lesions that, if identified early enough, can improve survival, and the pancreas cancer can be resected before it becomes advanced pancreas cancer or as a precursor lesion. So Dr. Aslanian nicely talked about pancreatic cyst, and the most common type of pancreatic cyst that we see, or particularly Dr. Aslanian and his team sees quite a bit, are intraductal papillary mucinous neoplasias, or IPMN. There's been a lot that's been learned about these kinds of cysts. Many patients are going through an ER and getting a CAT scan, and there are these incidental findings of pancreatic cysts. So we're finding that many patients, over 50% of patients over the age of 70, are diagnosed with these cysts. But most of these cysts are not high-risk cysts. They are low-risk cysts, such as Dr. Aslanian had mentioned. But we try to identify patients with these main duct cystic lesions of the pancreas that have a very high risk for converting into pancreas cancer down the road if nothing is done for it. So these are examples of early lesions that are identified with the high risk for developing pancreas cancer. There are entities such as mucinous cystic neoplasms as well. These are less common, but we see them not infrequently at Yale. And these are important entities as well too, because up to 30% of patients with these MCNs are eventually will be diagnosed with pancreas cancer, or are identified to have pancreas cancer in their surgically resected specimen. SPEN, or solid pseudopapillary neoplasms, also have a high risk for malignant conversion, and we also resect patients with these are identified as well too. And that number I put here is 20%. And PANN, there's some question about the conversion rate for malignancies, but I just put that there too because there's some medical literature that talks about that as well. This drives home some of that earlier slide, and it also touches a little bit about what Dr. Lacy was talking about. So we're working to identify at-risk populations for development of pancreas cancer, and the scientific technology that exists in 2023 is just as amazing. And there's been so much that's been advanced in the last 20 years, and just even within the last 10 years. But in this way, we're able to take a larger group of population, prioritize, potentially detect patients that have high risk lesions, and then we're able to do procedures such as Dr. Aslanian and the Yale Advanced Endoscopist, where a biopsy is able to be performed, and some such as these diagnoses that are listed over here. And then we understand a lot about the tumor biology, and you heard a lot about KRAS from Dr. Lacy, which is a type of oncogene that's mutated early in the development of pancreas cancer as well. So we're trying to find patients that are at-risk populations. Another advance that comes along with pancreas surgery, and this is more of is the multidisciplinary approach. So the best outcomes for patients with pancreas cancer and for other kinds of cancers is using a multidisciplinary approach to treatment, and that is especially true for pancreas cancer. One of the reasons that patients have had better outcomes related to pancreas surgery is our colleagues in radiology have had great advances in their ability for cross-sectional imaging. This means high-quality pancreas protocol scans, and these are CAT scans that are performed with very fine detail, where we're able to look at very fine cuts of 2 to 3 millimeters in thickness, or 2 to 3 millimeter cuts, looking at different phases of an arterial phase, portal venous phase. And this helps us very carefully plan out what the right approach is for a surgeon, a patient, and perhaps if surgery is the right thing or not, and the sequence of the approach as well too. So CAT scans and MRIs are substantially better, and we get them routinely on patients that we even consider surgery for, and those that we do not operate on as well. There's some selective use for PET scans. This is not something we routinely do for patients with pancreas cancer, but in select circumstances, if we're looking for a specific question, they have some utility, and there is some advantages to that in those circumstances. Our use of tumor markers as well too helps also identify patients that perhaps are high risk or not high risk. So whether or not the patient should undergo surgery first or undergo systemic therapy first. So tumor markers such as a CA19-9 help guide the decision making and help us guide whether or not patients would need what's called a staging laparoscopy prior to any sort of treatment for the pancreas cancer. And that's something we do on many of our patients after they've seen our multidisciplinary team. You heard about neoadjuvant and perioperative therapy by Dr. Lacy from a systemic therapy approach, and Dr. Du is going to talk a little bit later about the use of radiation therapy as well for a multidisciplinary approach for our patients. So these have all led to better surgical outcomes. A lot of folks want to know what is a Whipple procedure, and this is a basic cartoon of what a Whipple procedure entails. On the left, one sees a basic picture of the human body, of the abdomen and the pelvis, and on the upper abdomen is the liver. The stomach sits in the upper abdomen as well too, and towards the back, you'll see the pancreas and what's called the lesser sac, and the central and lower abdomen is the small intestine and the colon. And if one looks at the center picture here, this is basically what we focus on in the operating room, which is essentially the right upper quadrant of one's abdomen. So behind the stomach is the pancreas, and then one can see the pancreas in yellow here. And during a Whipple procedure, we divide the pancreas right where it's shown over there, usually over the neck of the pancreas, but it depends on where the tumor is located. And sometimes we do what's called an extended pancreatic duodenectomy. We divide the beginning of the small intestine at the level of the duodenum. Sometimes we do it at the end of the stomach. We remove the gallbladder and we remove the end of the bile duct. And we also divide the intestine at what's called the proximal jejunum, which is the second portion of the small intestine. And that is basically what's removed with the Whipple procedure. But like I had said in one of the earlier slides, an important part for treating patients is not just to get the cancer out, but it's also to maintain and have a good quality of life as well too. So after these organs are removed, or part of these organs are removed, we need to reconstruct it. And essentially that means we take a loop of small intestine, which is what was sitting in the central and lower abdomen, and we sew it to the pancreas. We sew it to what's left of the bile duct, and we sew it to the what's left of the duodenum, and sometimes we sew it to the stomach. So this is one of several ways that the GI tract can be reconstructed after the Whipple after a resection for the Whipple procedure. The second operation that we tend to do for this type of a cancer is called the distal pancreatectomy. And in this cartoon in yellow, one sees the pancreas again here in yellow, and there's a tumor here in light brown, which is in the tail of the pancreas. So for a distal pancreatectomy, what we do is we remove the latter portion of the pancreas. So what I tell patients in my clinic is the pancreas looks like a fish. It's got a head, a body, and a tail. So what we do in this Whipple procedure, in the distal pancreatectomy, is divide the pancreas at the tail, or sometimes the body of the pancreas, and we remove that with the spleen for pancreas cancer, because there's a lot of lymph nodes where pancreas cancer can metastasize to, and a good cancer operation entails removing the spleen for pancreas adenocarcinoma. In other circumstances, sometimes we'll spare the spleen, but not for pancreas adenocarcinoma. So there have been many technological advances over the last 30 years that have enabled for safe surgery. One is clearly surgical technique. We've learned a lot. We learn from each other, not just in the United States, across the world, about types of surgical techniques and surgical approaches which enable for safe Whipple procedures and pancreatectomies. One huge advance has been the advances in anesthesia and surgical critical care. So it's not just the surgeon in the operating room. Within the operating room, we have an anesthesiologist who we work very carefully with. We have scrub techs, we have circulating nurses. We have a whole team of folks in the operating room, and our communication within the operating room has become advanced and enables us to have better perioperative outcomes as well. Often our patients will go to the ICU, some patients will go to the regular surgical floor, but sometimes it entails close communication with our critical care doctors who help manage the patients in a perioperative fashion alongside us, which has improved substantially and led to some of the better outcomes. Interventional radiology has been a huge advance in the last 10 to 15 years. And our colleagues in interventional radiology allow us to address complications of surgery without undergoing another surgery. And this is often the case. So oftentimes with the Whipple procedure, or even a distal pancreatectomy, we're worried about fluid leaking from the pancreas, which happens 20 to 30% of the time, which is what's called a pancreatic leak. And instead of taking the patient back to the operating room to address that leak, oftentimes a radiologist, our interventional radiology colleagues can place a drain under some local anesthetic and some image guidance. Sometimes there's bleeding problems after a Whipple procedure, and that could be a challenging problem if it were to happen. And when it does happen, our colleagues in interventional radiology are usually the first people we call to embolize the area that's bleeding, and that saves someone another operation for this as well too. So huge advances in interventional radiology have helped improve the surgical outcomes. Advanced endoscopic techniques, so you heard a lot about that from Dr. Aslanian. So he and his colleagues helped us out substantially in not just getting a diagnosis within the US, but in ERCPs and other endoscopic interventions, which are extremely helpful for patients and have also improved the surgical outcomes as well too for patients. For example, if a patient has an obstructed biliary tree and their bile is backed up into their liver and into their bloodstream, oftentimes it's not safe to do Whipple if that number is so high for various purposes. So Dr. Aslanian and his team can sometimes put a biliary stent into place and drain that biliary tree and allow the patient to recover a bit too, and enable for a safer Whipple procedure or systemic therapy if that's the way we choose to treat the patients. And finally, centralization of pancreas surgery to specialists in high volume centers such as Yale. So at Yale, we have a very large experience of doing pancreas surgery in our multidisciplinary approach over here. And we've had excellent outcomes, amongst the best in the United States for pancreas surgery. And there's other centers also that have these kinds of nice experiences as well too. But having a multidisciplinary high volume center is critical for that. And all these points here that I mentioned on this slide are some of the reasons we've had safer surgery and better outcomes. We also have many advances in minimally invasive surgery, and we use a lot of minimally invasive surgery at Yale. So oftentimes we're doing laparoscopic surgery and robotic surgery as well to perform pancreas surgery, and it's pretty much standard for all of us to do laparoscopic distal pancreatectomies and sometimes robotic distal pancreatectomies as well too. So the advances of minimally invasive surgical techniques have also been an advance in surgical oncology. And the advantages are it can lower the length of stay in the hospital and lower the opioid requirements. And then we often have these enhanced recovery programs such as we have at Yale, which also have led to better outcomes. I put one slide about quality of life just because it comes up quite a bit and with patients in our clinics. And I want to say that patients go on to live a very good quality of life after a pancreatectomy. It's a major operation, but a majority of the patients go on to live a very good quality of life. They sometimes will have improvement of symptoms that they presented with when the diagnosis first came, such as if they presented with jaundice and itchiness related to the biliary obstruction, and that is relieved with the surgery. And patients have a very good, when you look at quality of life studies, physical, cognitive, emotional, and social aspects are very high scoring after pancreas surgery. But there are some changes that patients experience afterwards, and it's important for the surgeon to communicate with the patient over what some of those might be, and some of those may entail some changes to the GI function of a patient, and sometimes if those islet cell tumors are removed, that Dr. Muzumdar mentioned earlier too, some patients can become insulin-dependent diabetics. But overall, the quality of life for most patients is very good after the pancreas surgery. Tumor resectability is an important point to talk about. And this is something that Dr. Lacy had talked about earlier. So whenever patients see us in our multidisciplinary team, we want to get a good high quality pancreas protocol scan, and we classify patients into essentially 4 categories. We want to see if a patient has resectable disease, meaning the tumor is away from any of the important blood vessels. We want to see if they have borderline resectable disease, which means they have contact with some of the blood vessels. We want to see if they have locally advanced disease, which means they have substantial amount of involvement of the blood vessels. And we want to see if they have evidence of metastasis. And survival is associated with this presentation of resectability. Improvements in the cross-sectional imaging have enabled for us to get these precise selections. This is a very busy slide. I'm not going to go through the detail, but this is from what's called the National Comprehensive Cancer Network, which is a very important network that Yale is a member of, which provides guidelines for patients across the United States and across the world for guiding cancer care. So this is a table that's been developed by experts, including from our team here at Yale, where patients are classified into resectable, borderline resectable, or locally advanced pancreas cancer. And this just summarizes what that entails. And what we look at is what is the arterial involvement, and number two, what is the venous involvement as well too. And this is there's a reference down there too if you want to learn a little bit more about it. But I'm going to give you a few examples of some patients that we've treated here. This is an example of a patient that I treated with a resectable pancreas cancer. And then resectable means that in yellow is where the tumor is seen. It's hypoechoic in the way it appears, and that's in the head of the pancreas. And on the left here, on the left of this this PowerPoint slide, you see biliary stent. Next is in blue here is what's called the portal vein, superior mesenteric portal vein. That's a vessel that we pay a lot of attention to, and this is clear of it. And then to the highlighted in red over here is what's called the superior mesenteric artery, and the tumor has no contact with that blood vessel at all. So this is what we would call resectable. Next is borderline resectable. So borderline resectable has a few different appearances to it. The one we pay a lot of attention to is the involvement with the superior mesenteric and portal vein. And here on the left, you see in yellow, there's a tumor, and that's seen in hypoechoic as well too. And that tumor is pushing against the superior mesenteric vein and portal vein right over here. So you can see an indentation, and that's what a borderline resectable tumor can look like. And this is a cross-sectional view of the same patient. And again, in gray, there you see the tumor, you see the portal vein is contacted, but in red there, the superior mesenteric artery is completely clear. It's got a nice black fat plane around it, which means that there's no arterial involvement. And then there's locally advanced. Locally advanced means the blood vessel is involved over 180 degrees. So in this case here in the yellow, again, you see the tumor. In the red, you see the artery, and the artery has tumor around it on both sides. And then jumping to the right here too, once again, you see the tumor, and then you see the artery in red. And again, surrounding that artery is the tumor, which is what's called a locally advanced pancreas cancer. Patients that have vascular involvement, specifically borderline resectables, where we think a lot of in this kind of a scenario, and in select patients locally advanced, but oftentimes it's in patients with borderline resectable, which we think a little bit more about it. So this is where we can safely not just do the Whipple procedure, but in addition to doing the Whipple procedure, we can remove a segment of usually what's the portal vein or the superior mesenteric veins. And the reason we do that is to try to achieve negative margins, meaning microscopically and grossly. Very rarely is arterial indication indicated in this scenario, but once in a while there is a role. So that's a little idea of what this is going to show. And Dr. Du is going to talk probably a little bit more about that, because radiation can play a role, and particularly in this kind of a scenario and in other scenarios. So in summary, pancreas cancer is a leading cause for cancer deaths in the United States and worldwide. Identification of precursor lesions improves survival. The quality of life is very good after pancreas surgery. We talked about classification of resectability, resectable, borderline resectable, locally advanced. And we also talked about advances in surgical and non-surgical expertise, which have improved the perioperative outcomes. We talked about vascular resections. We talked about minimally invasive approaches. We talked about interventional radiology advances, advanced endoscopy, surgical critical care and anesthesia, and centralization of surgery. So in conclusion, there have been significant advances that have been made to improve the surgical outcome for patients in their battle against pancreas cancer. Thank you.
Thanks, Dr. Khan, for a great presentation. And we'll move on to our last speaker, Dr. Kevin Du, who's Associate Professor of Therapeutic Radiology medical director of the Radiation Oncology Center at Smilow Cancer Hospital and at the Smilow Care Center in Trumbull. And he's going to talk to us about radiation therapy for pancreas cancer. Don't forget to unmute.
Sorry.
You're good.
Thank you for reminding me how to use Zoom after 4 years. My name is Kevin Dew, and I'm an associate professor in radiation oncology. I take care of pancreas cancer patients, and also have the privilege of being involved in pancreatic cancer radiation clinical trials. So today, as others have been saying, is World Pancreatic Cancer Day, which is a really important way to shine a light on this disease and help with efforts to really try to cure this cancer. And thank you all for your participation in this Smilow Shares session. You know, just by showing up, you're really showing support for all our pancreatic cancer patients, and as well as our pancreatic cancer program here at Yale. So today, I'll talk about why we use radiation for pancreas cancers, what types of radiation we have, as well as the side effects of radiation, and finally, the work we're doing to improve cure rates in pancreatic cancer. So first of all, a very common question is, what is radiation oncology? I think most people have an intuitive understanding of what surgery is, what Dr. Khan does, what chemotherapy is, what Dr. Lacy does, but radiation tends to be more of a black box for many people. And the way I look at it is that as a radiation oncologist, I treat patients with radiation just like how Dr. Khan would treat cancers with surgery, or how Dr. Lacy will treat cancers with chemotherapy. And we work together as a team to design the best treatment plan for our shared patients. And a critical part of the team, by the way, is the patient. Radiation, we've been using this for over 100 years to treat cancers. And while in the early days, radiation, the side effects of radiation were not well understood, over the past 100 years, there have been really incredible leaps in understanding about the physics and the biology of radiation, and also big leaps in the technology that we use to drive our radiation treatments. And these have really made radiation an increasingly safer and effective treatment. And the most common way that we treat pancreatic cancers is with machines called linear accelerators. And here's a picture of a linear accelerator. And the patient lays down the treatment table, and radiation is delivered by X-rays that are emitted from the head of this machine, which can swing around the patient to focus the radiation. And the analogy we use is it's like spotlights on a stage, where there's a bright spot where we're aiming the radiation from multiple different angles. Within the head of the machine, there are metal leaves that we can move into the radiation beam to shape and modulate the lead to target the tumor and avoid normal tissue exposure. And so this is an example of one of our radiation treatment plans for a pancreas cancer. And this is, we're looking at a CT scan that's very similar to the ones that Dr. Khan just showed. And for those of you who haven't seen a CT scan before, these are basically bread loaf slices of images and looking from a patient from the feet through to the head. And here is the liver, and over here is the spleen. These are the kidneys, and back here is this wide area is the spine. And so this is the patient's back and the front, and the pancreas is really right in the middle of all these very important structures in the patient. And so the color areas that you can see are the radiation dose. And you can see that we're focusing the radiation right in the middle of all these normal tissues to effectively target the tumor while trying to avoid as much as possible all these normal tissues around there. So we do think about radiation as a focused, precise treatment, aiming radiation to kill off cancer cells. So why do we use radiation? Well, as you've heard, the pancreas is right in the middle of your gut, and it's surrounded by sensitive structures and blood vessels that make this a really complex and many times difficult surgery. Many times there's not a lot of space to get around the tumor. And as you've just heard from Dr. Khan, you need a lot of space to get those big margins where you can get all of the tumor out and have a successful cancer surgery. So when it's difficult to get big margins around the cancer, or even when surgery may not be possible, this is where radiation can really help. So we can use radiation before surgery to get tumors to shrink up so that surgeons can get those big margins around the tumor. Or we can use radiation after surgery to clean up any microscopic cancer cells left after surgery. And as Dr. Lacy and Dr. Khan have been talking about, pancreas surgeries, both pancreas surgeries as well as pancreas chemotherapy, cancer chemotherapy have really improved over time. And in the 1980s, we used to think that for patients who have had a Whipple surgery, that over 70% of patients would have regrowth of the pancreas cancer around where the cancer was removed, what we call local recurrence. And so at that time in the 1970s, 1980s, radiation was really felt to be an important part of treatment for pancreas cancers to clean up after the surgeries. A more recent study published in, say, in 2013 showed about a 45% of local recurrence after surgery, so better than the 1970s and 1980s. And in the most recent modern clinical trial that Dr. Lacy discussed, looking at really the groundbreaking treatment of FOLFIRINOX for resectable pancreas cancers, published in 2018, about 20% of those patients had local recurrence, regrowth of the pancreas cancer after surgery. So over time, local recurrences have decreased with better surgery and better chemotherapy, but it's still a significant problem where pancreas cancers can recur even after successful surgery. So with modern surgery, modern chemotherapy, does radiation help? Many times these days, if the surgeon is able to get big margins around the pancreas tumor, we think that the benefit of radiation is small. So we usually don't recommend radiation in those cases. It's really only in patients where the surgeon is really not able to get those big margins that we recommend radiation. And the question of the benefit of radiation after surgery is being looked at in this large national clinical trial, randomizing patients after successful pancreas cancer surgery to either radiation or no radiation. And this particular trial has actually completed enrolling patients, so we should know the results from this trial soon. And as very importantly, we personally enrolled a lot of patients into this trial, and I really have to thank them because their participation in this trial really will help us to understand which patients would benefit from radiation after surgery. This should be coming out in the next year or two. So what happens, and unfortunately, sometimes surgery is not possible. As Dr. Khan was saying, sometimes the pancreas tumor is wrapped around those blood vessels that really feed the rest of the gut, and you just can't remove those blood vessels. So only about 25% of pancreas cancer patients at presentation are really eligible for surgery. And while many times we can treat patients with chemotherapy or radiation to shrink up the tumor and get them to surgery, what about the patients where they are never able to get to surgery? This is really where radiation is very important as an alternative to surgery. So in these pictures, we have these colored lines showing how we're aiming radiation, again, on these CT scans at a pancreas cancer. And what happens is after radiation treatment, and here in this red arrow, you can see a pancreas cancer before treatment. After radiation treatment, the tumor will hopefully shrink up over time. And this is a picture a year later showing that this fullness of the tumor mass has shrunk up substantially, but you can still see something there. And it's rare, in all honesty, that the pancreas tumor goes away completely. on these CT scans. And sometimes we think that the tumor is under control, but still with viable cancer cells. Sometimes we think that maybe the imaging may just be showing scar tissue after the best case successful treatment of radiation. So the most up-to-date results for pancreas cancer response to radiation is that radiation can probably control the growth of pancreas tumors for approximately 1 to 2 years. And importantly, because pancreas cancers can cause patients symptoms, as Dr. Aslanian was talking about, that radiation has also been shown to improve the quality of life of patients after radiation, including pancreas-related pain. So radiation is unfortunately not as good as surgery, but there is a benefit from radiation when surgery is not possible. And we are also asking the really important question in radiation in my field of if we can do more with unresectable pancreas cancer patients. Can we do more than control the growth? And if we could potentially convert pancreas cancers from unresectable to resectable patients with radiation. And this is very preliminary. I wouldn't say at all that this is something that we would use regularly, but I would say it's something we need to look at more in clinical trials, and it's a very important thing for unresectable pancreas cancer patients. And this is a small trial, only a few patients with unresectable pancreas cancers treated with chemotherapy and radiation. And in this small experience, 60% of the patients who were initially unresectable could ultimately have a successful surgery after chemotherapy and radiation treatment. And here's what I call what we call a waterfall plot, which shows the responses of cancers in response to treatment. So the bars that go up here means that the cancer has grown through treatment. But you can see here that the majority of the responses, the bars go down, and that indicates that the size of the tumor is shrinking with treatment. And you can see that most of the patients actually have a response to chemotherapy or radiation. And in fact, there's this one patient where this patient has had 100% complete response to chemotherapy and radiation. That is that there were no viable cancer cells left after chemotherapy and radiation after the patient went for surgery. And that complete response is really important to think about. Even though it's just this one patient, it shows that it's possible. And if you look at across all chemotherapy radiation trials, series reporting the outcomes of chemotherapy and radiation, we see that about 10% of patients are consistently across all these series have pancreas cancers that respond completely to chemotherapy and radiation, again, with no residual cancer cells at the time of surgery. So this is a really important area of research in radiation. And the question is, how do we increase the complete response rate so that more patients can have this really ideal results where we can eradicate pancreas cancers without surgery? And this is a really critical question for patients who can't have surgery. And it's a clinical trial priority in my field to really try to get at this question, understand the biology of why this happens, and to try to increase the number of patients who have this. So what are the different types of radiation that we use? And I'll say again, most cases we will use the linear accelerator to aim X-rays at the tumor. Many times we're giving radiation over several weeks of daily radiation. 3D radiation means that we're using three-dimensional imaging like CT scans or MRI to visualize and customize our radiation plans. IMRT is intensity modulated radiation therapy, is a computer-driven technique where our radiation plans are shaped and modulated using treatment planning algorithms to make radiation safer and more tolerable. SBRT is a type of radiation technique where we're able to aim radiation with very high precision to give big shots of radiation over shorter treatments, typically 3 to 5 days instead of several weeks, so much more convenient for our patients. And then new radiation technologies are coming. And here at Yale, we have just started treating patients with what's called biologically guided radiation therapy. using a radiation machine, which uses PET scan guidance in real time to target tumors with increasing precision. Very exciting for visualizing pancreas tumors during radiation. And we have approval from the state of Connecticut to build a proton center, which is another type of radiation. Instead of using X-rays, using protons to deliver radiation. And the benefit of protons is that they are better able to avoid radiation exposure of normal tissues, and so they reduce the side effects of radiation. Our proton center at Yale has not been built yet, and Yale is working on getting funding for it. But once it's built, it'll be the first proton center in Connecticut, providing our patients in our state access to safer radiation treatments. So we're coming up on 8:30, so I'll just say that altogether, what I hope you get from this is that we're treating pancreas cancer patients with radiation is not a one-size-fits-all approach, that we customize radiation plans for each patient to maximize effectiveness and minimize the risk of side effects. And that overall, together with the team of other pancreas cancer experts like those on the panel, we come up with a tailored treatment package based on the patient sitting with us in the clinic room. So together, we are improving pancreas cancer cure rates, but we absolutely need to do more. And with the goal of curing more pancreas cancer patients in mind, clinical trials are how we find better treatments for our patients. And yet, this is really a sobering statistic that only 4% of pancreas cancer patients participate in clinical trials, let alone trials that look at how we can improve radiation treatments. That's a very low number, and we do need to do better to drive forward our pancreas cancer treatments and improve. These are a few examples of ongoing radiation clinical trials examining new technologies to better target radiation to the pancreas, how we might combine different drugs with radiation to take advantage of some of the biology of radiation and overcome ways that the cancer becomes resistant to radiation. This is including early stage trials looking at how radiation may modulate the tumor microenvironment to enhance the effect of immunotherapies, like this trial where we work to translate pancreas biology, looking at the tumor microenvironment to a novel clinical trial using next generation immunotherapy directed against immunosuppressive macrophages. So I'll end by repeating that clinical trials are how we find better treatments, and we really need to find we need to run more clinical trials for pancreas cancer patients, and we really need to have more patient participation so we can learn how to cure more pancreas cancer patients. Thank you. I'm looking forward to talking more with all of you and answering any questions you might have.
Thank you, Dr. Du, for that very comprehensive look at radiation pancreatic cancer. We have a couple of questions in the Q&A. I answered one by text given the late hour, but I will have the other one asked live to Dr. Lacy since it's relevant to what Dr. Du just described. How are patients selected for clinical trials?
That is a great question. It's probably not a short answer, but in general, trials have what are called eligibility criteria that patients have to meet to get into the study. And it relates to things like their stage of their disease. So there are some trials for resectable disease, which we discussed, the sequencing of FOLFIRINOX. There are trials for metastatic disease. There aren't a lot of trials for locally advanced unresectable disease, which Dr. Du is just addressing, which is problematic. And then there are issues with respect to prior therapies. So most trials will allow either no prior therapy or limited number of prior therapies, or you have to have had prior therapies. There are eligibility criteria that relate to blood work, hemoglobin, hematocrit, kidney function, liver function. So it actually is a high bar often for patients to be eligible for trials, and it can be frustrating, certainly for us, but definitely for patients, in that they were eager to seek out investigational therapies and are finding that they do not meet the eligibility criteria for one reason or another. That's a reality, something we would like to change. We all talk about having trials be more relevant to our real world patient population and the diseases that they have. but it is, there are very specific eligibility criteria for every trial. And that is what makes it difficult for both us and for our patients to figure out what is the right trial for them at that stage in their disease.
Looks like there are no other questions in the Q&A, and since we're beyond 8:30, maybe we'll stop. We want to thank all of you for joining us today. We were really excited to be able to share advances in pancreatic cancer care and our multidisciplinary approach to taking care of patients with pancreatic cancer at Smilow Cancer Hospital and Yale Cancer Center. And so have a good night.